Okay. Apologies again for the inconvenience. Thank you so much, Dr. Mdluli, and thank you so much to everyone who's in attendance today. Today we're gonna discuss an approach to pulmonary tuberculosis, but we're gonna look at in a microbiologist perspective, meaning we look at TB. We discuss TB from the microbiologist. How do they deal with it? But before I do that, I would like to take this opportunity and first appreciate Dr. Mdluli. Dr. Mdluli, I understand that you are a registrar, and the registrarship is very difficult. There's a lot, you have a lot of work, you don't have time, but you have decided to give us your time and your knowledge. Thank you so much for that. Without wasting any time, I'd like to take this opportunity and allow Dr. Mdluli to introduce herself and also tell us that what is a microbiologist, so that we are all in the same level. Over to you, Dr. Mdluli.
Thanks for the introduction. No problem, I'll just introduce myself quickly. I am struggling with a bit of flu, so I'm coughing, clearing my throat, drinking some water. It's just flu season now. So I'm a microbiologist by training, and I'm currently working with the NHLS, specifically with the Pretoria department here at what we call the Tshwane division. So as microbiologists, we're dealing with the unseen infectious world. So we're dealing with all the small microorganisms that you would appreciate under a microscope. The bacteria, you've got the umbrella of the mycobacteria, which is where TB would fall under. But we do much more than that. We also deal with mycology. So this is the study of fungi. So that also falls under our umbrella of expertise. We also deal with parasitology. And this is where you're going to appreciate some of your rare and wonderful diseases. But this is also where we actually see, for the first time, some of the organisms that we can actually see with the naked eye. Like the worms, for example, the parasitic worms. So you can see those with the naked eye. So we also deal with those. And although you have a separate field called virology, we are also trained to some extent to be able to deal with some virology. So we also do that. So it's a very, very broad field, but I think our bread and butter is basically microbiology. So we are basically the production team behind what happens in the medical departments. So we are receiving specimens, we are receiving samples from doctors who are suspecting an infectious agent. And the question that they're basically asking us is, what does my patient have? And they're asking us to make the diagnosis, and they're asking us to basically advise on treatment. So that's what we are doing. So every time you find yourself faced with a patient and you think that they have something and it's infectious in origin, we are the people who you're going to consult with regards to what specimens should you be taking. We can also advise you what tests you should be asking, and we will basically test the organism for you and tell you basically how you should be managing that organism. All right, so that's what I do in a nutshell.
Thank you so much, Dr. Mdluli. Without wasting any time, I think we'll just go straight to the question. Sorry, Doc? Apologies for that. Without wasting any time, I think we should just go straight to the questions. If you have a question, you can raise your hand. You can write in the comment section. And then I'm going to attend to that. But while you are still waiting for questions, Doc, I'm going to start with the question here. When is the patient infectious? When is the patient infectious? Immediately after diagnosis, before, or there's a duration?
So it's different for different patients. And you won't actually know when the patient is infectious. The one laboratory test that we can do to confirm that the patient is actually infectious is doing what we call smear microscopy. So what we do is we actually get the patient's sputum specimen, and if we see bacilli, TB bacilli in that specimen, then we can assume that every time this patient coughs, they're actually spreading those bacilli. But in terms of how long it will take for each person is going to be very much dependent on the individual person. So some people have got stronger immune systems. They might not be as infectious. Kids, we tend to find, don't spread the TB bacilli as much. They have what we call porcine bacillary disease. So porcine means few or little. So they actually produce very little bacilli. So children usually don't become infectious. So it's very much dependent on the patient, the immune system. It depends on the age. So there's many factors. But the one way you can confirm that a patient is actually infectious is actually doing what you call smear microscopy.
Okay, so now in general, let's say I've diagnosed the patient with TB, and I'm concerned that this patient is going to be transmitting TB. Maybe after starting treatment, how long the duration can I give the patient to, okay, maybe right now the likelihood of you spreading the organisms will be less likely than someone who's,
Yes. So again, it's very much dependent on what we call bacillary load. So some patients would have a very high bacillary load, and if they have a high load, it might be longer. However, we expect most patients within 2 weeks of proper therapy to actually not be transmitting the bacilli as they cough anymore. So 2 weeks is the general, but not always. There's exceptions. So like I mentioned, if the patient has cavitary disease, they've got a high load, then you might have the patient being infected for much longer periods.
Okay, I think that's answered the question. Thank you, Doc. Second question. So now, in a case where a patient skip a medication, maybe a day or two, in terms of microbiology, what is the recommended action? Do you ask the patient to take more dose or just continue? What is the recommended action after a patient? Let's say, okay, so the option one is the patient omitted the medication once, and then option two, the patient has omitted medication maybe for 2 days.
All right, so the first thing is, as clinicians, we like to get frustrated when patients are omitting medication. Understandably, it's understandable why. This is a condition of public health concern. We are concerned for not only our patients, but we're actually concerned for the community and society at large. So it's actually very irresponsible for somebody to omit meds. So we get very frustrated, but we need to empathize with the patient. We need to find out why is the patient skipping medication, because you'll never be able to rectify what's happening. So you need to find out what are the barriers to them taking the medication. Were they unwell? Were they struggling with full burden? Do they just not understand? Is it a misunderstanding? Did they not have access? You need to find out what the underlying reason is for skipping those medications, because that will be your entry point into how you're going to address the problem or the concern, and how you're going to counsel that patient, and how you're going to support them. So the important timelines is actually a month, more than 2 months. So there's a month and the period between 1 and 2 months, and the period more than 2 months. A patient who has skipped less than a month of treatment, after establishing why they have interrupted, you basically need to reinstate or reestablish the medication. And all that's going to affect is it's going to basically affect the duration of the phase. So you may have to extend, say, the initiation phase. Or you may have to extend, say, the continuation phase by the period of time that the patient missed the treatment. So that's the simple case. If the patient now has missed medication for longer than that, you still need to do your homework, find out why has a patient been interrupting medication. But at that point, you may need to now do microbiological testing to find out if the patient still has got sensitive organisms, because now there's a worry at this point that because they've been non-compliant for so long, we could now be dealing with resistant TB. So those patients, you're basically going to need to retest and basically find out, are you still dealing with sensitive TB or not? And then you're basically going to get direction after you get those answers.
Right. Okay. Thank you so much, Doc, for answering that question. I think you even answered the question I didn't ask, but thank you so much. When I was listening to your voice note, Doc, you were very careful to answer, to state that it's drug-sensitive tuberculosis. Some of us, such statement, they take it lightly, but the more you read on the condition and the more you understand, that's a very critical statement to mention. Now, having said that, how do we define MDR, which is multiple drug resistance?
Okay, so very important. The definitions have changed over time. So I'll give what is considered maybe the latest definitions, but it's probably the definitions that everyone is aware of now. So when we're saying sensitive TB, firstly, because that's the baseline, we're basically meaning that we're not worried for our first-line drugs. It means that we're able to use our first-line drugs, so we're happy. When we say MDR TB, so that is multi-drug resistant TB, we are talking about TB that is now resistant to our first-line drugs. So that is both rifampicin and isoniazid. So both of them have to be out before we call it multi-drug resistant TB. That now means our first-line regimen is compromised, and this person needs a special regimen. And unfortunately, we have another group of resistance, and this is XDR TB. This is now where you've got knocking out of fluoroquinolones as well as what we call our group A drugs. So this basically means it complicates basically the regimen that we have to give that patient, because it's knocked down basically the drugs that we would rely on after our first line and our drug resistant TB regimens. So it's just a classification system, and it basically tries to guide us in terms of what drugs are we going to be able to use for the patient, depending on how we define their TB.
Okay, just to verify that, Doc, I heard you very well. So you said MDR when both isoniazid and rifampicin are not sensitive, meaning are not working. Then that's where we say a patient has MDR, multiple drug resistance.
Yes.
Now, and then you said XDR, which is extreme drug resistance. It's when rifampicin, isoniazid, fluoroquinolone, and then you said the injectable drugs.
We're moving away from the term injectables. So we now use the WHO classification of drugs, and we say a group A drug. So when we have a group A drug, so it's a bit complicated because obviously we're not dealing a lot. XDR-TB is a specialist entity, but the World Health Organization has grouped TB drugs into group A, B, and C. So once you've got the fluoroquinolones, as well as a group A drug knocked out, you've got XDR-TB.
All right, okay. I think that's clear. Now, Doc,
and sorry, just before you move on, I just need to clarify that for MDR, it has to be both rifampicin and isoniazid, because you can have something called isoniazid monoresistance. So it can be sensitive to rifampicin, but if it's resistant to isoniazid, it's monoresistant. So that's not MDR yet. So that's why we emphasize that it must be both.
Okay, thank you so much for that. Now, Doc, are there any indications of if I'm dealing with a patient, let's say the patient is presenting for the very first time and they have MDR, is there any clinical indication, is there any clinical sign that I might see that, okay, maybe this patient is having MDR, or it's just purely a laboratory diagnosis?
Unfortunately, it is purely a laboratory diagnosis, and that's why we need to be vigilant and we need to basically test. That's the only way we'll pick it up. However, this is where good clinical history taking comes in. If you can take a history and you get in the history that the patient was exposed to somebody who was treated with multi-drug resistance TB, that is very significant. So that might be the first indicator for us to now start thinking this could be resistant TB. Otherwise, we'll only discover down the line as we're testing. However, a history should be the first clue that you could be dealing with resistant TB. From a clinical perspective, they can present similarly.
Okay. So now you mentioned that usually patients after 2 weeks, generally speaking, they become better in terms of. Okay, I see there's a question. I'm going to attend to it after finishing this. You clinically, generally speaking, the patient become better after 2 weeks. Now, in a case where a patient is having MDR or XDR, are we expecting that clinically the patient doesn't become better, or the patient do become better, but what is the case usually, generally speaking?
So it all depends on baselines as well. So a patient who was initially very chronically unwell, having very low reserves, having very severe disease, will take longer to get better, and this is regardless of whether they are presenting with sensitive or resistant TB. So patient baselines are very important. The regimens that we use for TB are very good. They've been refined over a whole lot of years. However, the way that we manage sensitive and manage resistant TB is very different. The intensive phase, for example, for your drug-resistant TB is longer. It's 4 months. It's not 2 months. So it's different how we manage them. But I think the most important indicator of how a patient is going to perform is actually the baseline. It's how they present it.
All right, thank you. Okay, so there's a question here. It says trace results means if it is the sputum too little, or it's just the microbacterial too small on the sputum. Oh, I think Mdluli is asking if on the results you ordered a test on the sputum and then the results came back as trace. What does it mean?
So a trace result, it has to do with, so this is what we call a molecular assay. So we look for certain markers, and we call them, you can call them DNA markers, if you will. And we've got a certain number of probes, or yes, you can consider them probes. So the probes are basically going to look for these DNA markers in the specimen. So if you've got an example, 4 probes, it's supposed to find 4 DNA markers, and then it's able to give you a full result. So what happens with the trace result is, out of the 4 probes, only 2 of them are able to find a target, and we can't find the other 2. So then it can't give a complete result. So that's, in layman's term, what a trace result is. It means that we have found some of the DNA targets for TB, but we were unable to find the DNA targets that would basically give us the full complete result. Then it gives it as a trace. So what it means for you now as a clinician is you got to look at your patient. If you really suspect that your patient has got TB, you've got to start them on treatment, and you've got to send us a culture, because culture is still our gold standard, and that's what we're going to basically use to determine if this patient really has TB or not. What it could also mean is that this patient had TB in the recent past, and we're now detecting DNA fragments, but the patient was treated. That's why you need to take a good history, because one of the things we're going to ask you is, was your patient recently treated? Because this is a problem with our molecular assays, that the DNA lingers for a long time, and even though the patient has been treated and the patient has been cured, because our assays are so sensitive and they look for the smallest amount of DNA, they'll find something. And then now we don't know if the patient has TB or not. So you need to go look at your patient. If your patient is unwell, start them on treatment and send us a TB mutant. If your patient is well and your patient has a history of having had TB recently that was treated, then you can just monitor that patient, and it's most likely with an artifact. So So in summary, trace means that we found something, but it wasn't enough targets for us to give you a full panel of results.
All right. Thank you, Doc. Zandile, are you happy? You can raise a thumb. Okay, number one. Right. So if there is another question, guys, you can raise your hand. You can type on the comment section. Doc, what is PCR? Because we one of the reasons I invited you, Doc, is so that you can clarify these terms. Because sometimes as clinicians, you hear order PCR, but the exact meaning of what am I ordering or how is it different, sometimes it lacks the understanding. So what is a PCR and how does it work now in terms of TB specifically?
Okay, so PCR stands for polymerase chain reaction. So it's a molecular methodology. So what happens basically is when we've got the TB specimen, we break up the cells to the point where we get to the DNA, and we basically make copies of that DNA, and we basically then use that to detect and see what we have. So that's what it is. So it's called polymerase chain reaction. So if you think about your NATs, which is basically nucleic acid amplification tests, all of those, NAT is like the big umbrella under which PCR falls, under which gene expert falls. So all these molecular things fall under the umbrella term of NAT. So PCR is basically a method. Yes, that's in simplest term. It's just a method where we basically amplify DNA and then we detect it to see what we have.
Okay. And then culture?
Culture, on the other hand, is where we actually grow the organism. So with culture, what we do is we take the patient's specimen and under laboratory conditions, we basically grow the TB organism. And that's important for us because now we have the organism. We can, number one, confirm that it's alive, that it's viable, because that's a problem with PCR. PCR tells you that you detected TB DNA, but it doesn't tell you if that TB is alive or dead, because DNA you will detect whether it's alive or dead, which is why, of course, we can do DNA on corpses or on post-mortem specimens, because it doesn't need to be alive. But in order for you to grow something, it needs to be alive. So culture is the one thing that will tell us that this TB is alive and it's replicating inside the patient. So we now have that organism and we're able to actually test it further so we know which drugs it's going to be sensitive to. So TB is very slow when it replicates. So when you order TB culture, be aware that it can take up to 6 weeks to get a result.
Okay. All right. And then I see there's a question. I'm going to come back to it. And microscopy, and how is it different between culture and NET, as you said, nucleic acid amplification test?
Yes. So microscopy is where we take the patient's specimen and we look at it directly under a microscope. So we basically magnify it 100 times over to basically see if we can see the TB bacilli. We won't be able to see them unless we use some kind of stain. We need to stain them to introduce contrast. Because these things in nature are actually colorless. So what we do is we've got two types of stain. We have what you might have heard of as Ziehl-Neelsen stain, yes, or it's also called an acid-fast stain. So we can use that. But we also have fluorescent stains, and the one you would have heard of is probably the Oramine stain. And these are much more sensitive. Of course, everything has got its pros and cons, but basically we have to stain the organism, and then we look directly under the microscope to see if we're detecting it. We can, with reasonable accuracy, tell whether it's TB or not, but sometimes we do pick up artifacts. But most importantly, it's difficult for us because there are other TBs. Microbacterium tuberculosis is not the only microbacteria out there. So it can be difficult for us sometimes sometimes to differentiate if we're looking at a different mycobacterium. So microscopy has that weakness in that we can tell it's a mycobacterium, but we won't necessarily know which one it is. But of course, if the patient has got respiratory symptoms, the most likely one is going to be tuberculosis.
Oh, also AFB, acid fast bacilli, it's a type of stain that you use under the microscope.
Correct, yes. And it's an important one for us because this is the one that helps us to determine the infectivity of the patient. And this is also the one that we use to monitor the patient. You cannot use a NAT or a PCR or a gene expert to monitor the patient because it's just a positive or negative. At the same time, we don't use culture because what culture does is you grow the organism, so you don't get a true reflection of the actual number of what was there because we're actually growing it over 6 weeks. Now, when you're looking at AFPs, it's the only one that tells you if the numbers is decreasing over time. Because you don't grow it, you just simply look at it. So that's why it's so critical because we're using it for monitoring. We're able to tell at this patient, the patient had 3+. Then the patient went on treatment, then the patient had 2+, 1+, etc. So it's a critical one for monitoring, and it's the only one you can use for monitoring.
Oh, okay. So for diagnosis, the most reliable and accurate one is culture, but for monitoring, the most reliable and accurate is acid fast bacilli.
Yes, but I would just like to clarify that that culture is what we call the gold standard. However, the faster to give you results nowadays, a smear can be fast, I suppose, but we consider, that's why we call them rapid diagnostics. So our NAT are very fast. Our gene expert takes 2 to 4 hours. So though they are very fast, they're faster than culture, but we still consider culture, as you mentioned correctly, to be the gold standard, and it's quite sensitive. It is the most sensitive.
Okay. So if now I have a patient in OPD, the test that I'm gonna order because of time frame, it's the acid fast, it's the NAT, nucleic acid amplification test.
100%. And there's multiple reasons for that. One is globally, we're just trying to standardize the way that we're doing this. And we find that the rapid diagnostics or the NATs are basically just the most cost effective and the most, they can expedite the answer. Culture, as already mentioned, will take too long. Acid fast bacilli staining can be inaccurate at times because it's dependent on who's looking in the microscope. But also, not all patients are going to have acid fast bacilli in their sputum. As already mentioned, children, for example, might not have. And then, so the NATs are very important because they do two things. One is they're going to tell you whether or not you've got TB, particularly Microbacterium tuberculosis. And secondly, they will tell you whether or not you've got sensitive or resistant TB. An AFB can't tell you if you've got sensitive or resistant TB. So the NATs are extremely fast. They give you an accurate answer and they immediately tell you how you should be managing the patient. So the World Health Organization has made a call that we should be using the NATs in a patient with suspected TB to make the initial diagnosis.
Okay, so Doc, you said NATs, nucleic acid amplification test, it's an umbrella term for all these molecular tests like PCR, gene expect and so on. Is that correct?
Correct, yes.
Now, if I'm in OPD and I've asked the patient to cough, what do I write on the form? Do I write NATs or what do I write?
All right. So our forms haven't evolved, so things have changed, but our forms have looked the same for many years. So if you turn, there is a place that says TB Direct. If you tick that, we will automatically do a NAT for you. But there's also an empty block. And what is encouraged is that you must write physically the words TB NAT there. And the reason is because laboratories have got different technologies. We, for example, at our lab had got both experts, and we're also using the newer test, which is called the TB Max. And we would rather you write TB NAT because we will look at the specimen, where it comes from. We'll look at the different labs, and based on that, we will decide then which nut we're going to do. So it's much easier if you just request TB nut instead of saying specifically gene expert.
Oh, okay. Okay, I see. On Tuesday asked the question of if we have a patient who we strongly suspect as TB, but the gene expert comes back negative, should we do what should we do? Because she asked if we do MCNS.
Yes. So always, not just for TB, for any test that you have, always manage the patient. Never manage at laboratory results. Always manage the patient. So that's important. So if you strongly suspect that the patient has TB and the gene expert, for example, has come back negative, you can send us a sputum for culture because that is the gold standard. But if you're sitting with an HIV positive patient, our algorithms at the moment make a call that you should take a second specimen for a repeat gene expert.
Okay.
So you can do a repeat gene expert, and you can simultaneously send us a culture, which will take a bit longer. However, there is room for what we call a clinical diagnosis of TB. So if you're sitting with a patient who's very unwell, sorry, has got a very suggestive history, has got a very suggestive exposure, maybe it's even HIV positive, has got a very suggestive chest x-ray, you can basically use all those signs and symptoms together and make what is called a clinical diagnosis of TB, and you are within your rights to manage that patient while you wait for a confirmatory diagnosis.
Now, Doc, how is PCR different from gene expect?
So it's not different. It's just that a gene expert is a term that is owned and coined by the company who made it up, Said. And what is special about them is basically they've got one, we call it a cartridge. It's like a capsule, and you basically put in the specimen, and it does all the reactions within that cartridge, and then gives you a result. So that's what Gene Expert does. Whereas a traditional, so within that cartridge, it's actually doing PCR. So within that cartridge, it's breaking up the TB, it's amplifying the DNA, and then it's measuring what we've got. So it's doing all of that. It's just that it's doing it in one cartridge. In a traditional PCR, you've got different sections in the lab, and in the one room, you're basically going to do the lysing of the organism, then you're going to take it to a separate room and you're going to do the amplification, and then you take it to a separate room where you're going to do the detection and so forth and so forth. So a traditional PCR, you can see you've got separate steps taking place in separate parts of the lab. What Said have done is they've combined all of it into a user-friendly and safe cartridge. And that is why you can actually do Gene Experts in the clinics and so forth, because it's now miniaturized and it's been made safe, because once the reaction occurs, it actually kills the bacterium. So it actually makes it non-infective in that cartridge.
Oh, so in other words, Gene Expert is an advanced PCR.
Yes. So Gene Expert incorporates PCR, but it does many steps, and it does them in this one little cartridge.
Okay, I think that's crystal clear. Now, in your voice note, Doc, you said the patient must, when you are asking for a sputum, it must be the first early in the morning, first thing early in the morning when they wake up. Why so, Doc? Is there a specific reason, clinical reasoning?
Yes. So during the night, you're less likely to cough and eat. So what happens is your secretions actually build up. So we find that there's the highest load in the morning secretions. So that is why we request the morning sputum. And also mention, you also decrease the chances of the patient having eaten and contaminating the sputum as well. But mostly it's because of the overnight collection of the tuberculosis. You've got a better concentrated specimen in the morning.
Right. Okay. I have one last question, and I'll give the audience after that. And if there are no questions, and then I think it will be come to an end. Now, my last question, Doc, is that after 2 months, which is the initiation phase, we need to test the sputum, as you already stated also in your in the voice note, that at week 7 we need to send the sputum. When we send the sputum at week 7, is it still or you said week 7 it's AFB again?
Yes, correct.
Okay. Now, what happens, Doc, if I'm sending a sputum and then the results come back as still positive?
So, as already mentioned, the patients usually become non-infective quite quickly. So we are very concerned for patients who still have got positive AFBs by week 7. So obviously it means we cannot change them now to consolidation phase. So what we need to do is we need to find out what is happening with this patient if they're still positive. And usually the thing we need to go and assess for is compliance. And we need to see if the patient is actually taking the treatment as indicated. If they are compliant, you actually need that patient's specimen, because we need to now check that are we really in fact dealing with sensitive TB here. And so this might mean that we may need to culture the specimen. We no longer do LPAs, which we used to do in the past. We are now doing away with those. So we may need to do culture, or we may need to run another molecular assay to just make sure that we are dealing with the sensitive strain. And if we are dealing with a sensitive TB strain, we would then basically reinforce compliance and continue treatment for a bit longer. As mentioned, there are those few cases of patients who may remain positive for a bit longer if they had a very high bacillary load at diagnosis. So that doesn't mean that the patient is resistant, but it's very, very few cases. The majority of them are going to be compliance issues, and there may be a small percentage who in fact turn out to have resistant TB.
Okay, and then same thing applies on week 23 towards the end, after the end of the continuation phase. If it's positive, then you still follow the same method.
Yes, but there is one big difference. The patient at this point has been on treatment for almost 6 months. So if the patient has got a positive sputum at this point, we have a big problem. You actually need to stop the treatment at that point, and the patient needs to be classified as a treatment failure. They failed treatment. And then at that point, you actually need to do drug sensitivity testing to make sure that all the drugs in your first line are actually sensitive. And then based on that, we would know then how to treat the patient. The concerning part is, of course, the majority of these patients, you'd expect that there's something wrong in terms of sensitivity with regards to their strain. But you actually need to stop the treatment because it hasn't been working for essentially 6 months. There's no point continuing it. You need to stop it, classify the patient as treatment failure, and then you need to get a workup of why the patient has been failing.
At which level, in all of this, Doc, at which level do you refer, because most of my colleagues are working at a primary health level, at which level do you refer now to a higher institution?
So it depends on, so a lot of the patients should be managed as outpatients. If they need a reason to be admitted, but a reason that does not have to do with stabilizing the patient, they can be managed by a TB center or a TB hospital. But if the patient is unstable for any other reason, heart disease, unstable diabetes, if they're admitted, say, for an unrelated reason like a trauma and they were incidentally found to have TB, then they would end up in a general hospital. So that's what differentiates the two, whether you go to a dedicated TB center or you go to a hospital. For patients who end up, so we don't want our patients with TB to be in hospital, if I can put it that way, because it's a risk for everybody else who's in hospital. So we only have patients going into hospital with TB if they cannot be taken care of anywhere else. I don't know if that helps.
Yes. And then if the patient is on week 7, the sputum is positive, do you refer or you continue to treat yourself?
So at week 7, like I mentioned, that there may be reasons why the patient, so at that point you can actually extend for a little bit longer while you trying to find out why the patient is still sputum positive. So I don't think you necessarily need to refer, but you need to consult.
Okay, and then definitely at week 23, that's where you refer.
Yes, I would definitely communicate with a dedicated TB center, because 6 months is a long time to take treatment and not be responding.
Okay, so this is the end of my questions. If there is anyone who have a question, sorry, there is a question here, Priscilla Twala, I'm sorry. If we started treatment with clinical diagnosis where GeneXpect was negative and then TB culture also come back negative for TB, should we continue with TB for 6 months or stop the treatment?
So that's an important question. We do not advise nor believe in a trial of therapy. So a trial of therapy basically means where you give the patient treatment, and if you find that they're improving, then you're going to stop. We don't believe in that. If you're going to make, if you're convinced that this is the case in keeping with TB, you need to dedicate the entire 6 months of treatment. That's why it's prudent to actually try and establish a bacteriological diagnosis of TB. But once you decide that this patient meets the criteria of TB and you're treating them, you have to complete the treatment.
All right. Are there any questions, colleagues? You can raise your hand, you can unmute yourself, you can type on the comment section. On my side, Doc, thank you so much. This was very informative session. We really appreciate your time and thank you so much again. And then apologies with the technical issues that took place prior. We really thank you, Doc. This is I guess this is the end of our session because I see that there are no questions. You are released, Doc. With the rest of the audience, guys, there is a survey of clinical associate. This survey is looking at, it's a research actually. It's looking at the clinical associate as a whole, and I'm kindly asking you guys to fill in the survey. It's few questions I'm gonna post in the group just now. Very few questions that will make an impact. That has an impact of changing the profession as a whole. Also on the drive, on the Google Drive, there's a link there, guys. I'm encouraging you to go there and give a feedback so that you can see which direction should we take. Are we doing well? Are we not doing well? I'm encouraging everyone. It's just we're just taking only 3 questions on the feedback session. So I'm kindly encouraging everyone to go on the drive. The link is in the description in the WhatsApp group. Go there, go on to the feedback session, go to the specific topic, and then leave a feedback. HPCSA, I can already see that people are leaving their details. You leave your name, your surname, and then the HPCSA number. Every month end, I'm gonna give a feedback regarding the CBD points. You can start leaving your details, name, surname, and then the HPCSA registration. But again, guys, I'm really begging you. Also, I left a survey in the group, but I see that not everyone has attended to that survey. And also, this is another survey. I just put this in the group now. After leaving your details, thank you so much. Enjoy the rest of your evening.
Thank you.
Thank you.